Today we are going to discuss the very important topic, that is the lab investigation interpretations of hyperlipidemia. I am Dr. Mehwish Sajjad from the Pathology department. This is very important topic that is closely related to the clinicals, as we all are, due to our dietary habits, are very prone to hyperlipidemias, and this is one of the most important screening tests which are uh, the physicians are suggested are the hyperlipidemias. Okay. Now the hyperlipidemias is the elevated concentration of the lipids in the blood. Okay. Now the objective of our uh, tutorial is to interpret the report of the lipid profile. How we, as a doctor, we interpret the report. How what are the parameters in the lipid profile report? What are the certain ranges which are given by the certain labs, associated labs, जिनसे आप करवा रहे हैं, उन्हीं की labs आपको जो हैं वो उनकी एक range देती हैं. So how to interpret the report of the lipid profile? So lipid profile having the following parameters like serum cholesterol, like serum triglycerides level, like serum HDL level, LDL level, and also VLDL cholesterol levels. So these are the following parameters which were given in the labs of the in the lab report of the patient. So when we suggested certain patient with the lipid profile, then actually what we are observing in the patient, we are observing the lipid profiles. We are observing these parameters like the cholesterol, like triglycerides, like HDL, LDL, and VLDL levels. Now, what is hyperlipidemia? This is the brief picture of the lipid profile report to you guys. Okay? If the patient is coming to you and they were taking up with the report, so what you will see, these are the following parameters. But the main concept is the what is hyperlipidemia? So hyperlipidemia, it's a very general term that is used to refer the chronic elevation in the fasting blood concentration of triglyceride, cholesterol, or a specific subtraction of each, whether it is LDL, whether it is VLDL, HDL. So it is the chronic elevations in the fasting blood concentrations of these lipid molecules or these lipids. And we have to counter with the two terms, that is the hyperlipidemia and also the dyslipidemia. So dyslipidemia is a term that is used for measurement of the concentration of the lipid profiles, whether it may be low concentration or it may be high. So dyslipidemia is basically the abnormal quantity of the lipids in the blood. It may be low, it may be high. Whereas the hyperlipidemia, is the name indicates, hyper means increase, so there is an increased concentration of the blood lipids level. So this lipidemia is maybe due to the genetic, maybe due to the environmental or the pathological factor that working together to abnormally alter blood lipid level. Alter blood lipid level means I stress on these words. It may be high or it may be low in the dyslipidemia and the lipoprotein concentration. On the next slide, we have defined certain other two definitions, like we have the hypercholesterolemia. It implies elevated blood cholesterol concentration greater than 240 milligram per dl. And hypertriglyceridemia is the elevated triglyceride concentration. So the hyper indicates increase. So the increased concentration of the any lipid component, whether it is LDL, VLDL, HDL, triglycerides, cholesterols, or the triglyceridemia. They're also called as hypertriglyceridemia. Now, first I give you the concept of the report, which we usually seen in our clinical practices of the lipid profiles, right? That they have a certain components like cholesterol, like triglycerides, like LDL, VLDL, HDL. Now, then I will give you the definitions of the hyperlipidemia, dyslipidemia, and all these. Now, in this tutorial, we have a certain chunks from all the subjects, like we have certain chunks from the biochemistry. As we all know, hyperlipidemia, so what are the dietary sources of the cholesterol? It might be monosaturated, polyunsaturated, saturated, and the trans-saturated fatty acids. So the main sources of the monosaturated fatty acids are the olive oil, we have the canola oil, peanut oil, and etc. Whereas, sorry for disturbance, wait a minute. Yes. So we are going towards, yes, dietary sources of the cholesterol. From the polyunsaturated fatty acids, we have the corn, we have the soya bean, we have sunflower, and the fish oil, seeds oil, and etc. Now we have these are the good for the health, as it decreases the LDL level and it increases the HDL level. So LDL is the bad cholesterol and HDL is the good cholesterol, and it is also a cardioprotective cholesterol. Whereas the saturated and trans-unsaturated fatty acids, they increase the LDL and HDL. Okay? And trans-saturated fatty acids increases the LDL level, and they are found in number of the foods as mentioned here. Now, the dietary determinant of the plasma cholesterol is intake of unsaturated and trans-saturated fatty acid. What they do, they reduces the expression of the LDL receptors that remove the cholesterol. That's why it is a bad cholesterol and it is unhealthy cholesterol. So when you saw the report of the patient, so you have a concept of the diet. Now we are started from the diet, from the biochemistry component, in which we take the dietary component of the patient. When you take the history of the patient, you take the history of the lifestyle of the patient. Okay? Or when you suggested the patient of hyperlipidemia, patient certain diet, then you suggested them the monounsaturated or the polyunsaturated fatty acids that are good for the health. So the main purpose of this slide is to assess the risk of the patient when the patient has a hyperlipidemia, what is its dietary habits, and on the other side we have to suggest the patient of the hyperlipidemia with a good diet that help in the lower the lipid levels in their cholesterol. Why? Because these fatty acids are by the LDL level. When the LDL level is increases, what it do, it decreases the expression of the receptor, LDL receptor, that removes the cholesterol. So here is an introduction of the plasma, that these lipids, that is LDL vagera, these are insoluble blood plasma, so they have to be transported throughout the body with the protein that is known as lipoprotein. Depending on the variation in the lipid and apolipoprotein composition as well as density, lipoproteins can be divided into four major types. Okay? Why there are four major types? Because they are different in the apolipoprotein composition, they are different in their density, and also there is a difference in the lipoprotein. So we have the chylomicrons, we have VLDL, very low density protein, LDL, low density protein, HDL, high density lipoprotein. Whereas we also have IDL, intermediate density protein. And here I give you a structure of the lipoproteins in which the outer covering, that is the blue, yellow, and the purplish type, shows the apolipoprotein. The centrally there is location of the triglyceride and the cholesterol esters. We have also sees the cholesterol with the red type of the, here there is a labeling here, and the phospholipids, the formula of the phospholipid is given here. So this is all about the lipoprotein. So when you seen that report, you have all these the dietary component, the structure of the lipoproteins and their functions, what they do. When we eat these dietary proteins, what they do, after the fat absorption, enterocytes uh, extracts monoglycerides and free fatty acids from the micelles and re-esterify them into triglycerides. Okay, what they do, they after the absorption, they re-esterify them into the triglycerides, and these triglycerides then combine with the apolipoprotein B48. Now this apolipoprotein B48 chylomicrons enter into the circulation via the thoracic duct, because we all know they are present in the lymphatic system. Further, they are remodeled by the transfer of the additional apolipoprotein. Now the chylomicrons are acted on by lipoprotein lipase that is located on the endothelium to release fatty acid, and the remnant chylomicron is cleared by the liver. Here you see the diagram. The whole procedure you can understand with the help of this diagram. What happens here when you eat certain fat diet? What it do? It will, the fat is absorbed in the enterocytes. Enterocytes is the intestinal cells. Okay, free fatty acids and the monoglycerides are released from the micelles, and then what happens here? You see in the diagrams that the lipoproteins is re-esterify them into the triglyceride. The blue molecule is the triglyceride. Now these triglycerides, when they re-esterify and they will join with the chylomicrons, they will combine with the chylomicron, that is B48. Okay, from where these chylomicron is come, that is entered the circulation by apolipoprotein B, and the chylomicron is coming here from the lymphatic system. Now they are further remodeled by the additional apolipoprotein. Now these chylomicrons are acted on by the lipoprotein lipase when they are circulated in the blood circulation. Now these whole molecule is acted upon by the lipoprotein lipase, which is mostly present in the endothelium, and they release the fatty acid. So after the absorption in the enterocytes, extract kiya, after that they will combine with these, they can re-esterify into the triglycerides. Triglycerides again attached with the apolipoprotein B48. This is attached with the chylomicrons, and when these circulated, these are acted by the lipoprotein lipase, which causes the release of the fatty acids, and these remnant chylomicron is then cleared by the liver. Okay, this is the whole procedure. Now the endogenous lipids. This is the lipids which was taken by us in the dietary form. Now here we have certain endogenous lipid, that is the LDL, VLDL, LDL. From where they are coming from? Chylomicrons are produced by the intestine, transport lipid of the dietary origin, poor in free cholesterol, has high lipid to protein ratio, and removed by the liver. So these are the chylomicron. These are the introduction of the chylomicrons. Okay? Now we have the VLDL. VLDL is produced, they are present in the lymphatic system. They are produced by the intestine, but they are present in the lymphatic system. And from the lymphatic system, they join these triglyceride and apolipoprotein molecules. Now we have the VLDL. VLDL is also known as very low density protein. They are produced by the liver. It supplies triacylglycerols and the cholesterol to the body. Now on the next slide, we have the LDL. That is the low density lipoprotein produced by the metabolism of the VLDL. Okay? When the VLDL is metabolized, it is produced, LDL is produced, and it is removed by the liver. Whereas the HDL is mostly composed of the protein. It is produced by the liver, and it is cardioprotective. Now I give you a brief background of all these parameters, that what they do, what are their pathophysiology, what is the role of the dietary protein in the hyperlipidemia. So one is the dietary protein, जिनका आपने फेट देखा कि वो आपके पास lipoprotein lipase के through chylomicrons में मतलब वो it will be split into the fatty acids. Now the other type of the lipid, that is the endogenous lipids, that's like the ways that VLDL is produced, LDL is produced by the VLDL. Now the HDL is produced. Now these all are the proteins in which LDL is the bad protein and HDL is the cardioprotective protein. So on the next slide, we have the HDL, the main function of the HDL. HDL is cardioprotective. Why it is cardioprotective protein? Because it helps in the reverse cholesterol transport. So what is reverse cholesterol transport? This is the whole concept. ठीक है कि आपके पास अगर HDL ज्यादा है तो क्यों ज्यादा होना चाहिए? Why you prefer why you suggested the patient the diet which was high in the HDL level, that or the things which will keep the elevated level of the HDL. Why? Because it is cardioprotective. Why it is cardioprotective? Because it has a phenomena that is known as the reverse cholesterol transport. Now what they do, when the peripheral tissues are gradually are guarded by the HDL against excessive cholesterol. Okay? So how they protect it? That is the apolipoprotein, A1 apolipoprotein. Here you see in the diagram of the reverse cholesterol transport, that what they do, that A1 apolipoprotein accepts cellular cholesterol and phospholipids from the membrane transporter known as ATP binding cassette A1 transporter. Here you see the diagram in which we have the intestine, the picture, the diagram of the intestine and the liver, and you see EPO1.A, and it gives an arrow towards the nascent HDL. And at the low level, on the left side, you see that we have a chylomicrons, we have the VLDL, and we have a different types of the protein triglycerides, right? Now this is taken up by the this A1 apolipoprotein that accept the cholesterol and the phospholipid from this ABAC1. Here you see in the diagram, okay, it will accept the cholesterol from all peripheral tissue through this ATP binding cassette 1A1 transport. Now this produces a small HDL. What they do, they produces a small HDL, nascent HDL. Here in the diagram, we have to say this nascent HDL accept more free cholesterol from cholesterol rich regions, right? What they do, ये produce करता है small HDL that is able to accept more free cholesterol from cholesterol rich region. Now what happened when they accept this cholesterol? The esterification of the cholesterol occurs by the help of the lecithin cholesterol acyl transferase, okay, LCAT, okay. Now what happens when the HDL accept this cholesterol? There is a esterification of the cholesterol taking place with the help of the molecule that is the LCAT, that is lecithin cholesterol acyl transferase, that maintain an uptake gradient. Okay, now HDL releases the cholesterol to the liver and the other tissue. It distributed the cholesterol evenly. HDL may transport cholesterol, VLDL, or the chylomicron in exchange of triglycerides by the action of the another enzyme that is the cholesterol ester transfer protein. Okay, here you have see that CETP in the diagram. Okay, it transfer cholesterol to the liver, to the other tissues with the help of, in the exchange of triglyceride with the action of the cholesterol ester transfer protein. So triglyceride level is elevated. When the triglyceride level is elevated, it reduces the HDL level, and it is very harmful for the patient's health. So it is all about the HDL. So in the previous slide, you saw the report, you saw the certain parameters. Now we have joining this parameters with the dietary lipid. From these lipids are coming from, so certain lipids are coming from dietary. Now you see that after absorption, what happens? It is cleared by the, it is associated with the apolipoproteins going into the circulation with the help of micro chylomicrons. After that, they are further release fatty acids with the help of the lipoprotein lipase, and the remnant chylomicron is cleared by the liver. After that, we have the endogenous lipids, like we have the chylomicrons, we have VLDL, we have LDL, we have HDL. And why the HDL is cardioprotective? Because of the reverse cholesterol transport, because it's taking cholesterol from the peripheral tissues and it distributed it to the liver in exchange of the triglycerides. Okay? And how they do with the help of the certain transporters like ATP binding cassette A1 transporter, they help in the transport of cholesterol to the HDL. Now the HDL is esterify these cholesterol with the help of enzyme that is the cholesterol acyl transferase. Now in the third step, this HDL, when it is esterified, now this cholesterol is transferred to the liver with the in the exchange of triglyceride with the help of the cholesterol ester transfer protein. So you have a concept of this cardioprotectiveness. Now what is the association of these lipids in the cardiovascular disease? हम मोस्टली क्यों करा रहे होते हैं? और अगर आप देखेंगे किसी पेशेंट का लिपिड प्रोफाइल एब्नॉर्मल आया है, तो फर्स्ट थिंग जो हमारे पास जाती है वो हमारे पास कार्डियोवास्कुलर डिजीज की तरफ जा रही होती है. सो लिपिड्स एंड द कार्डियोवास्कुलर डिजीज. सो लिपिड्स, plasma lipoproteins are major modifiable risk factors for the cardiovascular disease, because hyperlipidemias एक ऐसा factors है, you know, कि cardiovascular disease में we have the two types of the risk factors. Modifiable, that can be changed with the help of the diet, with the help of the exercise, with the help of the medications. And the other factor is the non-modifiable factor, that has a strong family history like genetic predisposition. Hereditary factors are there. So the plasma lipoproteins are the major modifiable risk factors for the cardiovascular disease. How? Why? Because when there is an increased level of the LDL, it leads to the contribution of the atherosclerosis. Increased plasma concentration of LDL and the deposition of the fats, what they do, they reduces the diameter that favor the subendothelial accumulation of the lipoprotein. Okay? In the lipids, in the endothelial, subendothelial layer. Furthermore, chemical modification takes place, oxidation is there, so there is no clearance. आप हमारा immune system जब कोई chemical modification नहीं हो सकती, like oxidation हो गई, तो immune तो what happens? They will not remove in from the blood vessels, from the layers of the blood vessels. It further triggers the inflammatory response, during which they will take up by the macrophages because they are not being destroyed by anything. So what happens? The immune system is activated, macrophages is there, they engulf this and they causes the formation of the form cells. Here you see in the diagrams. When you see in the diagram, what happens? Chylomicron monocytes adhesion हुई endothelial layers में, subendothelial layer में, they are modified LDL because they are not uh, their oxidation takes place, they are not removed by anything. What they do two things. They further trigger the inflammatory response, and on the other hand, the macrophages are activated and they engulf this modified LDL and they causes the formation of the form cells. And the form cells is the hallmark of the atherosclerosis. So atherogenic lipoproteins have an adverse effect on the endothelial function. So whenever you saw the report of the lipid profile, what you see when there is a elevated level of these lipids, so first thing come in your mind is the atherosclerosis procedure, that the process of the atherosclerosis is triggered or not. So we have to treat the, because all the management of the patient is depend on this. If what we do, we give the anti-inflammatory drugs, we give the statins to reduce the cholesterol levels. Okay, so the whole pathophysiology is this, that they causes the subendothelial predisposition, they causes the triggering the inflammatory response and causes the formation of the form cells. Now, on the other hand, the cholesterol laden cells. What is the cholesterol laden cells? The cells which have a high cholesterol concentration release cholesterol to the HDL, like we was discussed here in the previous slide, that the reverse transport mechanism. What they do, that they give cholesterol to the HDL for the reverse cholesterol transport to the liver for excretion, that the जो excess fat या lipids हैं, that will be removed out from the body. They will, with the help of the HDL, with the help of the cholesterol transport liver reverse cholesterol transport mechanism, which we discussed previously, to the liver for the excretion, for the removal of them from the body. So the HDL may counteract release cholesterol. To HDL may also counteract some components of the inflammatory response. So low HDL level predisposes to the atherosclerosis. So when in the report we have high HDL, normal within ranges HDL levels, and the low LDL, IDL and VLDL levels, so we say that these report is in normal range. Whereas when we see any report which have a high LDL level, high triglycerides, high VLDL levels, but low HDL levels, then we can say on the basis of this report, the patient is prone to develop atherosclerosis, or they are going to develop cerebrovascular diseases. So this is the whole concept, from the dietary protein, how they absorb, from the sources of the dietary lipids towards the endogenous lipid, how they absorb, how the different proteins prone to the cardiovascular disease, and how they protect from the cardiovascular disease. Now the next slide is the etiology of hyperlipidemia. Why it's happened? Primarily due to genetic predisposition. जिसमें हम कुछ नहीं कर सकते. There are certain genes which are coming from the family, which are running from the family. Associated with high morbidity and mortality, defects occur in the lipid metabolism and transportation genes. Basically, in the primary defect, we have defects in the genes. And in secondary, we have certain factors like diet, like medication, underlying disease like diabetes mellitus, hyperthyroidism, nephrotic syndrome, Cushing disease, and the alcoholism. Okay? Obesity, sedentary lifestyle, they all are prone to towards the hyperlipidemia. Now we have the individual causes of the individual proteins, of the lipids, like triglyceridemia. What are the causes of the hypertriglyceridemia? Is the acromegaly. Why the acromegaly occurs? Acromegaly is occurred due to increased growth hormone, and growth hormone leads to the hypertriglyceridemia. Alcoholism in the burns patient, in chronic renal disease. अगर आप chronic renal disease में कोई भी पेशेंट को नेफ्रोटिक सिंड्रोम के साथ देखेंगे ना, तो उसमें कोलेस्ट्रॉल लेवल बहुत हाई हो जाता है. ठीक है, अगर आप जब आप लोग अपनी नेफ्रोलॉजी करेंगे तो उसमें आप देखेंगे कि नेफ्रोटिक सिंड्रोम इज एसोसिएटेड विद द हाई कोलेस्ट्रॉल, हाई hypertriglyceridemia. diabetes mellitus, glycogen storage diseases, hyperandrogenism in the woman, lipodystrophy, pancreatitis, systemic lupus, and polyclonal gammopathy, and the obesity. These all are the causes of the hypertriglyceridemia. Whereas the causes on the next slide, we have the causes of the hypercholesterolemia. We have anorexia nervosa, cholestasis, Cushing syndrome, growth hormone deficiency also causes hypercholesterolemia. Like we have that is the obstructive liver disease, malnutrition, malabsorption, myeloproliferative disease, chronic infection. We have the deficiency in certain nutrient deficiencies there. We have tuberculosis, monoclonal gammopathy, and the chronic liver diseases like hepatitis. They all are the cause of the hypercholesterolemia. What are LDL hyperlipidemia occur due to malnutrition, due to obesity, due to certain drugs, due to steroids, probucol, isoterinon, and the progestins. These are the causes of the LDL hyperlipidemia. Now here I show you the certain drugs that also causes hyperlipidemia, and they specifically increase certain things like anabolic steroids. They increase the total cholesterol, they increase LDL level, and they decrease the HDL level. So it is highly when the doctors prescribe a patient a certain anabolic steroid, certain steroid, then they have to take care. There is a certain limit of the usage of this steroid because it leads to the development of the atherosclerosis because it lowers the HDL level, which is cardioprotective. Anticonvulsants increases HDL like phenytoin. Epilepsy में आप use कर सकते हैं. Atypical antipsychotics, they decreases the HDL level and increase the triglyceride level, whereas the beta blockers decrease HDL and the triglyceride levels. Corticosteroids, they increase total cholesterol, LDL, HDL, triglyceride, and VLDL all. Cyclosporin increase cholesterol and the LDL. Estrogen therapy. Now the estrogen. Why the female? Here is a very important point from the estrogen point of view. You see that the women before menopause, they are less prone to develop the cardiovascular diseases. They are less prone to develop the atherosclerosis. Why? Because of the presence of these female hormones. That is the estrogen. Why? Because it decreases the cholesterol level, it decreases LDL, but it increases HDL level, which is cardioprotective. So the women are protective due to their hormones, and after menopause they have equal chances of development of atherosclerosis like the male. Like before menopause, they have less chances of development of the atherosclerosis due to the presence of these total cholesterol increase karta hai. We have the phenothiazines, progestins, also protease inhibitors, retinoids, and the thiazide diuretics. They also causes the hyperlipidemia. Now, how you suggested certain, आप कैसे suggest करेंगे hyperlipidemia? Because most patients are asymptomatic for many years before the disease is clinically evident. ठीक है, generally कैसी presentation होगी? Patient with the metabolic syndromes have 3 or more of the following, like abdominal obesity, atherogenic dyslipidemia. Atherogenic lipids कौन से होते हैं? LDL, VLDL, these all are. Increased blood pressure, insulin resistance with or without glucose. That is, we have the what we have type 2 diabetes, ठीक है, glucose intolerance, prothrombotic state, or the pro-inflammatory state. If the patient have these type of the symptoms, then we have suggested the patient with the lipid profile. ठीक है, symptoms नहीं आते, बहुत अरसे बाद आते हैं. जब atherosclerosis develop हो जाता है, उसी के बाद आ रहे होते हैं. Non to severe chest pain, palpitation, sweating, anxiety, shortness of breath, dyspnea के साथ patient आ सकते हैं. Loss of consciousness or difficulty with speech or movement, abdominal pain, and sudden death due to cardiac arrhythmias, due to the cardiac arrest is there. So clinical presentation में होता है कि mostly अगर आपके पास कोई patient अपना बहुत कम है within पाकिस्तान के, वो अपना thoroughly yearly annually checkups कराते हैं, वरना mostly किसी जो है वो उस पे आ रहे होते हैं, किसी symptom पे आ रहे होते हैं. So if you see any patient who have a abnormal abdominal circumference or obesity, having a family history or having a history of diabetes, of the hypertension, so you can say you can suggest the patient with the lipid profile. Signs, what are the signs? None to severe abdominal pain, pancreatitis, eruptive xanthomas, peripheral polyneuropathy is there, high blood pressure, body mass index high होता है आपके पास. मतलब अगर आप देखें कि if there is a greater than 30 kg per meter square, waist size is greater than 40 inches in men and 35 inches in women, it is suggested that these are the certain signs that suggested the patient can have the hyperlipidemia. लैब टेस्ट में आपके पास टोटल कोलेस्ट्रॉल इंक्रीज होगा, एलडीएल, ट्राइग्लिसराइड, एपोलाइपोप्रोटीन बी, सी रिएक्टिव प्रोटीन. सी रिएक्टिव प्रोटीन इज इंक्रीजेस, व्हाई? बिकॉज इट शोज द इन्फ्लेमेटरी रिस्पॉन्स. ठीक है, सी रिएक्टिव प्रोटीन किस में कराते हैं हम? इन्फेक्शंस में भी कराते हैं. अगर सी रिएक्टिव प्रोटीन किसी का इंक्रीज आया तो वी कैन से देयर इज एन इंक्रीज इन द इन्फ्लेमेटरी रिस्पॉन्स आल्सो. We have the low HDL levels. Other diagnostic tests are also there. Lipoprotein, homocysteine. Homocysteine is one of the important factor which causes in the development of the atherosclerosis. Serum amyloid A, small L, dense LDL with the help of electrophoresis, HDL subclassification, apolipoprotein E isoforms, apolipoprotein A1, fibrinogen, folate. So chlamydia pneumonia titer, lipoprotein associated phospholipase A2, omega-3. These are वेरियस टेस्ट जो कि आपके पास हो सकते हैं. फास्टिंग ग्लूकोज, ग्लूकोज इंटॉलरेंस टेस्ट, वी कैन ऑल suggested the different tests for the interpretation of the HDL. Now the levels of the HDL. ठीक है, classification. Total cholesterol, if it is less than 200, it is desirable. Between 200 to 239, borderline. Greater than 240, it is high. It is considered as high. ठीक है. Now the total cholesterol level, they have the different ranges. Different laboratories follow different guidelines, and these, according to their guidelines, they write their ranges. Like you see in the आपने देखा होगा कि उसके अंदर different labs के अंदर different ranges होती हैं, तो वो जिस guideline को follow कर रहे होते हैं उसके according दे रहे होते हैं. LDL cholesterol should be less than 100, it's optimal. Between 100 and 129, near or above optimal. 130 to 159, borderline high. 160 to 189, high, and above 190, it is very high. Now we have the triglycerides level. Triglycerides less than 150, normal. 150 to 199, borderline. 200 to 499, high, and 500 is very high. So all values are given in milligram per dl. ठीक है, ml के हिसाब से हम दे रहे होते हैं. Now the next slide is the आप किस तरह से उनको जो है वो टेस्ट को वो करेंगे. Wait, participants are there. Okay, I see कि आप लोग हैं यहाँ पे या क्या है? So we are coming on the test. Wait a minute. Yes. How can you prefer? आप कैसे उसको बोलेंगे पेशेंट को? आप फास्टिंग लाइपोप्रोटीन प्रोफाइल, फर्स्ट थिंग इज इन द फास्टिंग. ठीक है, इंक्लूडिंग टोटल कोलेस्ट्रॉल, एलडीएल, एचडीएल, ट्राइग्लिसराइड, दे ऑल मे बी कवर्ड इन द लिपिड प्रोफाइल. Should be measured in all adults of 20 years of age or older at least once in every 5 years. ठीक है, you have suggested 20 years के बाद अब 5 years. Again, it is based on which गाइडलाइन योर फिजिशियन इज फॉलोड, क्योंकि हर गाइडलाइन में अलग दिए हुए हैं. अगर आप रॉयल्स कॉलेज की देखें, डिफरेंट अगर आप सोसाइटीज की देखें, तो हर एक की अपनी गाइडलाइंस होती हैं जो कि ईयरली एनुअल बेसिस पे चेंज होती हैं. Measurement of plasma cholesterol, triglyceride and HDL levels after a 12-hour or longer fast is important because triglyceride may be elevated in non-fasted individual. Why the fasting is necessary? Because the triglyceride may be elevated in the non-fasted individual. Total cholesterol is only modestly affected by the fasting. Second, we have the diagnostic parameters. Diagnostic parameters, what we have? We have two determinants, 1 to 8 weeks apart, with the patient on a stable diet and weight and in the absence of the acute illness, are recommended to minimize variability and to obtain a reliable baseline. अगर हमने चाहे मतलब हम देखना चाह रहे हैं कि तो कैसे कि हम दो रिपोर्ट्स लेते हैं, दो डिटर्मिनेशन लेंगे, एक से 1 to 8 week apart. ठीक है, if the cholesterol is greater than 200 milligram per dl, a second determination is recommended. अगर किसी पेशेंट में आया है कि उसका अबव आया है तो हम सेकंड डिटर्मिनेंट करेंगे विद द गैप ऑफ 8 वीक्स. ठीक है, and if the values are more than 30 milligram, if it is variable between 30 gram, the average of 3 values should be used. फिर हम उसको इस तरह से suggest करेंगे. Now the diagnostic parameter after a lipid abnormality is confirmed, major components of the evaluation are the history, including age, आपको पता है अब आजकल तो इतनी डाइटरी हैबिट्स इतनी खराब हैं कि बच्चे को भी आप हाइपरलिपिडीमियाज हो सकता है. जेंडर फीमेल मेल्स आर मोर prone to develop the cardiovascular disease as compared to the female until the age of the menopause because of the presence of the estrogen. Female menstrual and estrogen replacement therapy, physical examination, and the lab investigations are there. Now we have the assessment. Complete history आपने ली, presence or absence of the cardiovascular risk factors like diabetes, like hyperthyroidism, type acromegaly, family history of the premature cardiovascular disease, or we have the lipid disorders. Like आप पूछेंगे कि family में run करती है नहीं करती. Presence of absence of the secondary causes of the hyperlipidemia, including medication. If the patient is taking any medication like steroids, if the patient is taking steroids, then he has a hyperlipidemia after a certain time period. So we have to exclude the history of the medications. मतलब हमें history लेनी है medications की. Presence or absence of xanthomas, abdominal pain, or the history of pancreatitis, renal or the liver disease, like in the nephrotic syndrome, peripheral vascular disease, abdominal aortic aneurysm, or the cerebral vascular disease, like carotid bruit or stroke, or the transient TIE, transient ischemic attack. So these all are the presence or absence of the डिजीज. लाइक आपको अगर आगे आप देखें तो आपको ये हिस्ट्री मिलेगी. ज़ैंथोमास मिलेंगे जो कि ज़ैंथोमा ट्यूबरोसा जो कि जॉइंट्स पे आपको मिलते हैं. ज़ैंथेलिस्मा पैल्पेब्रम जो आपको जो है वो आइस के नीचे डिपोजिशन में आपको मिलते हैं. ज़ैंथेलिस्मा कॉर्नियल आर्कस में आपको मिलते हैं. तो ये सारी कंडीशंस हैं जो कि आपको इसमें मिलती हैं. सो व्हाट आर योर after this your tutorial, if you see that the patient आपने certain parameters देखे, आपने उसको associate किया with the dietary intake, फिर आपने देखा dietary intake के बाद फिर क्या होता है lipids का. After that you will see the endogenous lipids. In endogenous lipid we have the certain lipoproteins जो जिनमें there are certain lipoproteins which have a cardioprotective effect. वो क्यों cardioprotective होते हैं वो आपने देखा with the reverse cholesterol transport. LDL क्यों जो है वो lethal होता है because of the it helps in the procedure of the atherosclerosis. ठीक है. फिर आपने देखा कि individual causes देखे triglyceridemia, cholesterolemia इन सब के. After you give the individual आपने उसके causes के बाद आपने borderline measurements देखी, which again I told you कि it depends on the किस पे डिपेंड कर रही होती है, on the guidelines, the lab or the physician कौन सी guidelines को follow कर रहे हैं. After that अगर patient आपके पास आया, आपने देखना है कि आपने उसको कब prefer करना है. If there is any history of family history हो गई, कोई भी ऐसी history हुई डायबिटीज की या एक्रोमेगेली, तो आप उसको सजेस्ट कर सकते हैं. आफ्टर दैट आपने देखा कि पेशेंट को आप कब लेबल करेंगे हाइपरलिपिडीमिया. अगर एक में ग्रेटर देन 200 आ रहा है तो हम 8 वीक्स के बाद दोबारा उसको रिकमेंड करेंगे. अगर 30 ग्राम ml की वेरिएबिलिटी आ रही है तो वी विल टेक द 3 रीडिंग्स. ठीक है. एक और सजेस्ट करके और फिर हम उसको हाइपरलिपिडीमिया कहेंगे. फिर उसके बाद आप हिस्ट्री लेंगे पेशेंट. जब पेशेंट आएगा तो आप कैसे एक्सक्लूड करेंगे, कोई मेडिकेशन तो नहीं ले रहा, उसकी डाइटरी हैबिट्स कैसी हैं, उसका लाइफस्टाइल कैसा है, आप उसको रिकमेंड करेंगे डाइट्स. एज यू सी दैट द मोनोसैचुरेटेड और अनसैचुरेटेड फैटी एसिड्स, इस तरह आप उसको अच्छी डाइट को सजेस्ट करते हैं. फिर आपके पास आ जाता है कि वो डाइट जिसमें HDL इंक्रीज होता है और LDL कम होता है. फिर उसके बाद आपने क्लिनिकल साइंस देखे जो कि आपके पास आया ज़ैंथोमास और ये सारी चीजें, तो आप क्लिनिकली साइंस में देख रहे होते हैं. और बाकी सिम्टम्स क्या होते हैं, एब्डोमिनल पेन हो रहा, चेस्ट पेन हो रहा होता है, पैल्पिटेशन, स्वेटिंग, दे आर अनेबल टू टॉक, जो इसे आप एंजाइना में या कार्डियोवास्कुलर डिजीज में देख रहे होते हैं. तो इट्स ऑल अबाउट द लैब इन्वेस्टिगेशन इंटरप्रिटेशन ऑफ द हाइपरलिपिडीमिया. कि अगर आपके पास HDL बढ़ा हुआ है तो आप क्या इंटरप्रीट करेंगे, अगर आपके पास LDL बढ़ा हुआ है तो आप क्या इंटरप्रीट करेंगे, और अगर आपके पास जो है वो बढ़ा हुआ है, आपके पास अगर VLDL या ट्राइग्लिसराइड्स बढ़ी हुई है तो आप उसको क्या रिकमेंड करेंगे. नाउ काइंडली गिव मी अ क्वेश्चन इन योर चैट. आई विल आंसर योर क्वेश्चन. Any questions? Give me an email address, so I will email one of your fellow, and then मतलब उसके बाद आप लोग जो है वो अपने क्लास फेलोज को कर सकते हैं. ठीक है. तो आप लोग मुझे कर दीजिए. Anorexia causes hypercholesterolemia because when the patient is anorexic, what they do, They are in the starvation mode, in the malnutrition mode. When there is a malnutrition, there is a cachexia, there is a protein less. When the protein, इसमें आपके पास metabolic symptoms आ जाते हैं ना, तो उसकी वजह से क्या होता है कि जब protein loss होता है body से, तो आपका cholesterol level increase हो जाता है. I will give you one email address. I email to Chandani. She will email to all of you. ठीक है, आप इनसे ले लीजिएगा तो वो आपको कर देंगे. So this is the procedure. किसने मुझे question किया था ये वाला? Zen. Then this is the thing that how the anorexia causes the hypercholesterolemia, because of the cachexia, because of the losing of the protein, it causes the मतलब hypercholesterolemia. Any other question? Any other question? मतलब आपके पास क्या होता है कि कुछ प्रोटीन्स आपके पास मेटाबॉलिक जो हैं वो मेटाबॉलिक आपकी चेंजेस आ जाती हैं, जिसकी वजह से आपके एंजाइम्स में और इन चीज़ों में फ़र्क पड़ता है, तो उसकी वजह से आपके पास जो है वो आपके पास जो है वो कोलेस्ट्रोलेमिया इन पेशेंट्स में हो जाता है. So Arzu, you asked, can you explain the relation of HDL and increased triglycerides? No. HDL and increased triglycerides का जो रेशो है वो ये है कि HDL, देखिए HDL जब रिवर्स ट्रांसपोर्ट करता है ना, रिवर्स कोलेस्ट्रॉल ट्रांसपोर्ट मैकेनिज्म करता है, तो वो क्या करता है कि वो एक्सचेंज करता है, जब वो दे रहा होता है ना, आप जब वो एक्सचेंज कर रहा होता है कोलेस्ट्रॉल HDL के उसमें, तो वो इन एक्सचेंज ऑफ ट्राइग्लिसराइड्स कर रहा होता है. ठीक है, ये नहीं होता कि HDL इंक्रीज हो गया तो ट्राइग्लिसराइड्स भी इंक्रीज हो गए. HDL इंक्रीज होना चाहिए, इट इज कार्डियो प्रोटेक्टिव, बट ट्राइग्लिसराइड्स जो होते हैं ना वो कम होते हैं. अगर HDL होगा तो ट्राइग्लिसराइड्स अपनी एक नॉर्मल लिमिट में होंगे. ट्राइग्लिसराइड्स डायरेक्टली जो है ना वो HDL या ट्राइग्लिसराइड्स एक साथ हो सकते हैं बढ़े हुए, लेकिन कम होते हैं. हमेशा आपके पास होता है कि कोरिलेशन है, आपके पास लो ट्राइग्लिसराइड्स होंगे और हाई HDL लेवल होंगे. ठीक है, इस तरह से होता है. अगर आपके पास ट्राइग्लिसराइड्स ज्यादा हैं तो HDL लेवल कम होते हैं. वो क्यों होते हैं? क्योंकि कार्डियो जो रिवर्स कोलेस्ट्रॉल ट्रांसपोर्ट है उसकी वजह से, बिकॉज व्हेन HDL गिव द लिवर द कोलेस्ट्रॉल, इट विल टेक द ट्राइग्लिसराइड्स. ठीक है, तो ये आपके पास है. होप यू कैन अंडरस्टैंड आरजू. नाउ द कार्सम, विच बुक टू स्टडी? बेटा मैंने आपकी ये जो है ना रिवर्स, ये मैंने डेविडसन से बनाया है, क्योंकि मुझे पैथोलॉजी की बुक में मिल नहीं रहा था. आपका ये क्वेश्चन है ना, ये मुझे मिल नहीं रहा था बिल्कुल भी, तो इस वजह से जो है वो मैंने इसको डेविडसन से बनाया है. आपका लेक्चर एथेरोस्क्लेरोसिस के ही टॉपिक में रॉबिन्स के अंदर थोड़ा सा हाइपरलिपिडीमिया के बारे में दिया हुआ है. एनी अदर क्वेश्चन? Any other question, please? No? Okay, give me an answer. Now I ask a question from you guys. Give me an answer in your chat box. So why HDL, which lipoprotein is protective? Assume that you are in your clinic, in your I will give you certain scenario. Okay, then give me an answer. You are in your clinic, Doc Saab, a patient is coming to you and taking the report of the lipid profile. He has a high level of the triglycerides. He have a high level of the LDL. He has a high level of the HDL, and the cholesterol is above 200. So what you recommend to your patient? First, what is your diagnosis? First, what is your diagnosis? And second, what you recommend to your patient? Anyone? If the patient is coming to you, he has a high hypertriglyceridemia. Okay. So what you directly, Paula, do you directly prescribe the patient statins? Yes, then is right, that dietary modification, statin and exercise. So again, what do you think why these LDL or high triglycerides are are not good, why you take all these measures that you suggested your patient dietary modification or the statins or the exercise? Why the LDL or high LDL, high triglycerides are bad for the health? What is the reason? What is the reason behind it? Give me an answer in your chat. Why you consider LDL high triglycerides levels are harmful to the health? Because of the risk of atherosclerosis. Very right. How the atherosclerosis develop? LDL. What is the role of LDL in the development of atherosclerosis? What it do? It causes plaque formation, right? But what it do? It also endothelial damage. When there is a Sidra, you are right that, and Rashida, you are also right that Zan is also right. There is a multiple things taking place. There is a free radical. There is endothelial damage takes place, which causes the formation of the firm cells. Yes, Rabia, you are right. That is a formation of the firm cells, which is the hallmark. Okay. Now tell me, okay, what is the role of the HDL? Why HDL is cardioprotective? You're right, Minha, that there is a deposition of the lipid and intimal layer. So can you tell me about what is the role of the HDL? Why it is cardioprotective? Anyone? It's a good cholesterol. Sumaya, you are right. Why it is a good cholesterol? Give me a reason. Because it is cardioprotective. Why it is cardioprotective? It takes left. Very good, Zan. Very good. Very good, Arzu. It is a cholesterol transport. Good. So why, acha, this is another question. Why the females, acha, okay. A female is coming to you at the age of 23. He has taken the hyperlipid profile कि मुझे लगता है मेरा सांस फूल रहा है सब कुछ. And the patient and another female is coming to you with the age of 50 years. So आप कैसे, how can you measure the risk of the development of atherosclerosis in both the patients? If the patient, a female is coming to you with the age of 23 and a female is coming to you of 50 years of age. So which is more prone to develop atherosclerosis? You are right, Sumaya. You are right, Hussain, Rashida, Ahmeda, Navera, because due to estrogen, 20 years old is at low risk. So assessment क्या होगा? Because 20 years patient is lower to prone to develop atherosclerosis. Why? Why they have a low risk of development of the atherosclerosis due to the presence of the estrogen. And the 50 years patient, Sidra, she has a high risk of the patient. Okay. If the patient is all right, the patient is giving you a history of the usage of certain drugs. Can you tell me the name of certain drug that causes hyperlipidemia? Kindly, can you give me the names of 2 to 3 drugs which are very helpful in the which causes the increased lipid level in the blood circulation? Can anyone? Give me the name of 2 to 3 drugs that causes the hyperlipidemia. Hurry up. Anticonvulsants, right. T. Very good. Steroids, progestin, isotretinoin, phenothiazines, anticonvulsants. If the patient have a history of epilepsy and they uses the anti-epileptic drugs, and the most common is the steroids. So I think cyclosporin, you are very right. Rabia, everyone is right that we have the history. Acha, if you have a patient in your with the lipid profile reports, so आप उसको डाइटरी रिकमेंडेशन कैसे बोलेंगे? किस तरह से आप उसकी डाइटरी रिकमेंडेशन बोलेंगे? क्या आपको खाना चाहिए? कौन से मोनोसैचुरेटेड, पॉलीसैचुरेटेड, सैचुरेटेड और ट्रांससैचुरेटेड? व्हाई यू व्हाट आर योर सजेशन फॉर द पेशेंट? अगर आपके पास क्लिनिक में एक पेशेंट बैठा है, yes, so can you tell me why the dietary determinant is important? Why the dietary determinant of plasma cholesterol of saturated and unsaturated fatty acid is more harmful? I told you a point. Why? Can anyone tell me why these are harmful? Have anyone noted this point कि why these are saturated and saturated fatty acids are harmful to the health? No, due to high LDL. Exactly, this is the point. What they do? When they raise LDL, so what they do? What they do, I will tell you. They reduce the expression of the receptors that remove cholesterol. So this is the point. I think you missed that point, but I tell you why these trans fatty acids or the saturated fatty acids is harmful, because it increases the LDL, and when they increase, it causes the reduction of the expression of those receptors that help in the removal of the cholesterol. Okay, and also due to the formation of the free radicals, it's good, but the most important point is it reduces the expression of the receptor. This was given in the Davidson. ठीक है, मैंने Davidson से बनाया है. उसमें आपको जो clinical biochemistry and metabolism है, उसमें आपको disorders of blood lipids and lipoproteins में ये मिलेगा. उसमें आपके पास dietary lipids, endogenous lipid जो है वो important होते हैं. Yes, we should take polyunsaturated fatty acid that are rich in the omega-6 like walnuts. Walnuts is very rich in cholesterol. ठीक है, जैसे कुछ लोग ओबीज होते हैं, वो क्या करते हैं, पूरे लिपिड्स को बिल्कुल अपनी डाइट से खत्म कर देते हैं. इट्स अ बैड थिंग. हमें गुड कोलेस्ट्रॉल लेना है, लाइक द वॉलनट. वॉलनट डिक्रीजेस द बैड कोलेस्ट्रॉल. ठीक है ना. सो ये है. इसके अलावा मैं आपको बता देती हूँ कि ये वाला है. बाकी रॉबिन्स में से जो है आपने कहाँ से पढ़ना है, ये चैप्टर है पेज नंबर 491 है. एथेरोस्क्लेरोसिस का टॉपिक है, जिसमें इनमें हाइपरलिपिडीमिया, मेजर मॉडिफाइबल रिस्क फैक्टर्स में हाइपरलिपिडीमिया एक छोटा सा टॉपिक इन्होंने दिया हुआ है, तो उसमें से करना. ठीक है बेटा. एनी अदर क्वेश्चन और वी शुड माइंड अप नाउ. आपको कोई क्वेश्चन, कोई आपकी कोई ऐसा कॉन्सेप्ट जो आपको समझ नहीं आया तो वो आप देख लें, बिकॉज इट इज ऑल्सो एसोसिएटेड विद द बायोकेमिस्ट्री. ये जो LDL वगैरह हैं, ये सब आपको बायोकेमिस्ट्री में से बहुत अच्छे मिल जाएंगे. एक इम्पॉर्टेंट थिंग जो मैं आपको बताऊं, वो वाइवा में आप लोग कवर कर चुके हैं. फीमेल्स का आ गया आपके पास. इसके अलावा डाइटरी प्रोटीन्स का रोल आ गया आपके पास. HDL, LDL, कार्डियो प्रोटेक्टिव, LDL इज मोर मतलब होता है, वो आ गया. इसके अलावा क्लिनिकल साइंस आप देख लीजिएगा. दूसरा इंपॉर्टेंट, अगर आप बायोकेमिस्ट्री के लिहाज से पूछें तो यू शुड नो कि प्रोटीन टू लिपिड रेशियो, जैसे HDL के अंदर प्रोटीन रेशियो बहुत ज्यादा होता है. तो दीज आर द BCQs जो कि आपके पास एग्जाम्स के अंदर आते हैं. ठीक है, तो ये आपको पता होने चाहिए कि कौन सा LDL HDL में किसका प्रोटीन रेशियो ज्यादा है. ठीक है, कौन किससे प्रोड्यूस हो रहा है. लाइक जैसे आपने देखा कि मैंने आपको बताया है कि जो काइलोमाइक्रॉन्स हैं ये इंटेस्टाइन से प्रोड्यूस होते हैं, एंड दे वर और ये लिम्फेटिक्स थोरेसिक डक्ट्स के थ्रू जो है वो सर्कुलेट कर रहे होते हैं. तो यू शुड नो, ये आपको बहुत ज्यादा कवर करेगी बायोकेमिस्ट्री में. ठीक है, तो यू शुड नो द सोर्स ऑफ ओरिजिन ऑफ दीज लिपिड्स, VLDL, काइलोमाइक्रॉन्स, HDL, व्हाट आर देयर प्रोटीन टू लिपिड रेशियो. ठीक है, और ये कितने क्वांटिटी में होता है, ये सब आपको पता होना चाहिए. सो बेटा, थैंक यू वेरी मच. होप यू कैन अंडरस्टैंड दीज, और आपको समझ आया होगा. ठीक है फिर. ओके जी. ओके बेटा, अल्लाह हाफिज.
ओके मैडम, अल्लाह हाफिज.